Okay, thanks everybody, and welcome to the latest in our MAHSC series of inaugural lectures. So this is a half an hour session with Bilal Alkhaffaf. So I'm just going to hand you over to Phil Cowra to introduce today's speaker.
Thank you very much, Peter. Yeah, it's a real pleasure, this. I'm Phil Calrus. I'm nephrologist at Salford Royal Northern Care Alliance, but I'm a colleague of Bilal's, and the Alkhaffaf name goes back a long way in my clinical lifetime, and I'm really pleased to see that Bilal's father is online with us because I used to work with him. So Bilal has been a consultant in esophagogastric surgery, upper GI surgery at in the NCA for over 12 years. I think he'll tell you more about it, but he's done a lot of work in gastroesophageal cancers and in particular looking at surgical outcomes. So it's a real honor for him to be awarded this MAHSC chair in surgery, and well deserved. So with that very, very short introduction, to give you more time, Bilal, over to you, and you can tell us what you've been up to. Okay, thank you.
Thank you, Phil. Thanks for the canned introduction. As you rightly said, this appointment is, of course, a significant professional milestone and one that I'm really proud of. But nonetheless, it is a milestone and it's a means to an end and not an end in and of itself. And what you realise very quickly is that whilst these titles absolutely do open up doors to opportunities and collaborations, they also result in a much higher expectation, great expectations from colleagues and those you work with as well. And I hope to touch upon some of those opportunities later in the talk. But preparing this talk really has given me an opportunity just to pump the brakes a little bit, to reflect, to reminisce about the nearly 3 decades since starting medical school, and acknowledge the key people who've influenced my course to date. So I'm going to cover 3 topics with you today. Firstly, a little bit about my personal background and my slightly unusual and belated foray into research. I'm going to give you a whistle-stop tour of some of the research and training work that I've been involved in over the last decade. And finally, some of the work we're leading that aims to impact our patients over the next 5 to 10 years, both within the field of upper GI surgery and beyond, and within Manchester and beyond as well. So it is really easy to brush over the influence of an investment from other people, including your parents and family, your colleagues and your mentors, all of whom shape your personality, your character, your beliefs, your principles, and your behaviours. And I have to say, when watching some of the other MAHSC inaugural lectures, I learned more about my colleagues by listening to their personal stories and their backgrounds, their influences, more so than listening to a long list of successes or achievements or prizes that they've won. And I think it's also important that junior colleagues wanting to pursue a career in research need to hear that success or development in research is always preceded by failure, and often a long list of failure, and that this road is not either linear nor is it predictable. In my training years, I often looked at professors and academics as people who were always successful, but that, of course, couldn't be further from the truth, as I've learned myself. And so I want to spend the next 10 minutes or so just talking a little bit about my personal journey into medicine, surgery, and beyond. So my story begins abroad. My mum was born in Cairo in the 50s to parents from Egypt and Scotland, of all places. And then they moved to the United Kingdom, where she grew up. Her background is that she's a teacher, she's an educationalist, she's a linguist by trade, and worked in a variety of different roles, including teaching in inner city schools, colleges, and universities, including Manchester University. She was a chair of examiners for EdXL, where she developed the curriculum for Arabic GCSE and A-level, and she continues to share her knowledge and experience as an educational consultant to this day. Phil, you've already mentioned my dad briefly, but my dad was born in Mosul in northern Iraq in the 1950s, where he went to medical school, before coming to the UK in the mid-70s to start work as a junior doctor. He trained as a general surgeon in Greater Manchester at the Royal Oldham Hospital and Withington Hospitals, which is, of course, part of Manchester Foundation Trust now. And ultimately, he was appointed as a consultant vascular surgeon in Burnley in the early 90s, before moving on to Blackburn Royal when the trusts finally merged. Now, looking back, whilst neither of my parents necessarily pressured me into a career in medicine, it's clear that they really didn't need to. Working long and sociable hours, moving from one place to the next, teaching, training, constant development were all elements that were ingrained into the environment in which I grew up. And that, I'm sure, had a subconscious effect on my career decisions. I rocked onto the scene in 1979 in Marston Green Maternity Hospital in East Birmingham. And we lived in the Midlands for about 6 months or so before moving to the Royal Oldham Hospital. And we lived in the hospital accommodation there as my dad was working there at the time. Shortly after, my sister was born, and we lived there before moving to Leeds. Then we moved to Cairo, where I went to school for a while. We went back to Leeds. Then we went to Lyon in France, again, where I went to school for a short while, before moving back to Leeds, again, where I attended 3 different schools: Meanwood Primary, Lawrence Oates Middle School, and finally Allerton High School in Moortown. When I was 14, we moved again. And this time we moved to Manchester after my dad's consultant appointment. And I joined Altrincham Grammar School for boys. And this was probably the longest I'd stayed put in any one place for any significant length of time. And I really do think that a lot of this movement has served me well. We know that a career in medicine is punctuated by constant movement, constant dynamism, and I think it built a certain type of resilience within myself, which has definitely served me well. I stayed locally for medical school at Manchester. I'd had enough of moving around, and I joined there in '98. And from a very early stage, I knew I wanted a career in surgery. And that really helped me focus on my choices pretty early on. It fit my personality, and seeing my dad's work whilst growing up, I pretty much knew what I'd be getting myself into. Now, I'm often asked by our residents, our junior doctors, why I chose to go down the road of upper GI surgery. And I think that once you have an idea which area of medicine you want to go into, most of us could probably have worked in a number of different subspecialties. I toyed with orthopedics for a while. I even thought about vascular surgery like my dad, but I also wanted to plough my own furrow. And the reality is that I was heavily influenced by several mentors in upper GI surgery in my early days. But I also owe a lot of gratitude to several non-upper GI surgeons who were on the screen, who supported me along the way in one way or another as well. My first ever job as a house officer was with Simon Galloway and Ian Welsh at Wythenshawe Hospital, both upper GI surgeons. One of my first SHO jobs was with Bart Decat and Ansel Agwinobi at Stepping Hill, both upper GI surgeons. And one of my very first jobs as a very junior registrar was with Bob Pearson and Alan Lee. And by that time, the deal had been sealed. And I then went on to Preston, where I'd spent 18 months as a senior registrar, going to then Salford with John Vickers, Laura Formella and Kirsha Akhtar, and then returning to Manchester Royal Infirmary to complete my training with Bob Pearson and Alan Lee. Upper GI surgery as a specialty encompassed a spectrum of different pathologies. It wasn't just one super specialist niche area. It included cancer, it included benign surgery, and obesity management as well. Some of these procedures included complex and challenging operations such as esophagectomy for cancer. It was and remains at the cutting edge of surgical innovation, as we're going to be talking about today. And in particular, the early adoption of minimally invasive surgery in both obesity and cancer management are just some of the reasons I was drawn to this specialty. And I'm glad to say that my clinical practice continues to encompass all three specialisms of cancer, benign disease, and obesity to this day, largely thanks to these trainers and mentors. Now, you may have noticed that the title of the slide also says supporters, and I think it's the right time now to acknowledge my biggest supporter, who's of course my wife Dina, and she's a consultant GI radiologist in her own right, and an excellent one at that. And I simply would not have gotten through many of the challenges of training and consultant life without her continued guidance, advice, and support. At the end of my surgical training in Manchester, I was lucky to spend some time in South Korea for a fellowship with Professor Yang's very impressive team at Seoul National University Hospital. And just to give you an idea of some of the experience that we gathered or that I gained from there, this hospital performs over 1,000 stomach surgeries, 1,000 gastrectomies every single year. And I'm going to pick up on that a little later on in the talk. But to this day, I am still using both operative and non-surgical approaches to managing patients that I picked up during my fellowship. And that was an extremely valuable time for me. So you'll have noticed that I've said absolutely nothing about academia and research so far. And it's really easier to assume that someone who's currently doing research has always been involved in research from an early stage. And that's just simply not the case for me. I didn't get the best grades at university. I had to resit my year 4 examinations. I failed my written MRCS exams twice. And during my training years, my experience of research was very mixed. I had some minor exposure to research. I got a couple of publications which got me over the line for my CCT. And I still remember to this day being roped into undertaking a project that was clearly, in hindsight, going nowhere. I'd spent weekends and evenings locked in an office, going through volumes of written notes with non-existent supervision, just trying to find my way around. The focus at that time for both me and the training program team at the time was very much on clinical training. It was the peak of MMC, or Modernizing Medical Careers. And the focus was very much on getting through your training, getting through your clinical training and coming out the other end. And this was beneficial for me. It allowed me to gather some clinical momentum. And that's really important as a surgeon. And I was able to complete my surgical training within 10 years of graduation. So how did I end up in research, and when did this journey begin? Well, my appointment as a consultant surgeon at Manchester Royal Infirmary in 2013 happened in the midst of a decade-long attempt to centralise upper GI services in the region, and in particular with respect to cancer and emergency work. Upper GI surgery is a specialty that treats patients who tend to be older, who tend to be frailer, and with multiple medical conditions. Diseases tend to be far more advanced, and the treatments are often complex and aggressive and associated with significant rates of complications. What's more is that the volume of cases treated each year is small, and so there was a real need to focus that expertise in a very small number of centres with the aim of improving outcomes for patients. And one of the many arguments that was being made at the time by the different centres vying for this top spot was that this single regional centre should be based at the site delivering the best clinical outcomes. However, as I was to learn, the reporting of clinical outcomes is a hugely grey area. And it wasn't really until I began gathering our own unit's data to make our own case to be that centre, that single regional centre, that I realised that there was absolutely no consensus on what we should be measuring or how we should be measuring it to accurately determine how effective these complex and high-risk treatments that we were offering were to be for our patients. And when you scratch beneath the surface, you realise that, in fact, this problem is not only endemic to clinical practice, but it's also endemic in surgical research and all clinical research, in fact, and contributes to vast levels of research waste. And for years, certainly within surgery, the focus has always been on short-term results, such as 30-day morbidity and mortality, without any attention being paid to longer-term or even patient-reported outcomes. So I was really at a crossroads. I felt that I was left with a choice. I was either going to carry on as before, just kind of go with the flow, or try to make some kind of impact on the field. But as we all know, trying to start some form of research interest as a full-time clinician in the NHS is pretty impossible, with all the competing interests, with the service interests that's you're completely engulfed and drowning in, and especially as a surgeon who needed to maintain their surgical skills. And so I needed to learn from my previous mistakes within research and my previous experience. And I decided that really the only way that I could start this process would be with ring-fence support and funding. So I applied for an NIHR doctoral research fellowship grant with the support of my fantastic supervisory team who are on the slide. And I started a part-time PhD as a consultant. And that was really my first structured entry and experience into formal research. The application process was all very last minute, but thankfully, and lots of thanks to the NIHR for trusting in me, they awarded me a £400,000 personal award to develop a core outcome set which aimed to gather international consensus with respect to what outcomes we should be reporting in surgical trials for gastric cancer. And importantly, this consensus process would keep the patient perspective at its heart, which had been missing all along. Now, this project was extremely well supported by national and international professional, surgical and nursing bodies, and importantly, patient groups. We were really lucky to gather some fantastic traction from colleagues from across the globe, including the Far East, that really bought into this. And we needed their buy-in simply because most of the gastric cancer surgery occurs in the Far East, where the incidence is highest. And of course, much of the work was driven by a core team made up by our international working group. However, in particular, our patient partners were involved in all stages of the study design and were critical in making this a success. We were able to recruit 1,000 surgeons, nurses, and patients from 55 countries across 6 continents. And importantly, there was a significant proportion of patients coming from low and middle income regions, which had never been done before. The project took nearly 5 years to complete and highlighted many of the challenges in the development of this area of the development of core outcome sets. And by exploring these challenges, this study also made a number of methodological contributions to the field that other teams have subsequently benefited from. For the first time, a final core outcome set comprising of 8 outcome domains was agreed by patients and healthcare professionals. And some of these outcomes, such as surgery-related mortality, may have been expected. But interesting, some of the other outcomes, such as nutritional outcomes, had certainly never been reported in trials before. We then took a step back and looked back at how these 8 outcomes, important to both patients and clinicians, have been reported in the literature over the last quarter of a century. And as expected, this was highly variable, and the longer term outcomes, such as quality of life and nutrition, were most affected by this poor reporting. And the reasons are pretty obvious. These are difficult outcomes to report. So my interest in outcome reporting essentially came about because of a perceived threat to the clinical service that I worked in. And this work rapidly resulted in the development of a large network of researchers, clinicians, and patients. And this has since and will continue to serve our patients' needs in the future as we develop more projects and studies in this area. Now, what ensued, both in parallel to the gastro study and as a direct result of the gastro study over the last decade, has been nothing short of exhausting. And it's not until you get these opportunities like the one I have today that you get the chance to reflect on what's actually been achieved. So I'm going to spend the next few moments just sharing some of the key highlights from the last decade, which I've tried to summarize here. how this international network has been able to work together and impact patient care, and what the future might look like as well. Once we worked out which outcomes should be reported, the next natural step was to understand which tools we should use to measure these outcomes. And this has resulted in several collaborations to undertake international multi-center validation studies with colleagues to look at both the established tools that we have for measuring these long-term outcomes, but also to develop novel tools to report long-term outcomes, such as the symptoms that patients get after these complex surgeries. Closer to home, our group also realised that there was massive overlap with core outcome sets in the field of surgical oncology. And given you can't afford to spend 5 years and several £100,000 developing a core outcome set for every specialty in this day and age, we opted to develop one that could be applied to several specialties at once. And this work is being completed by one of our PhD students and will be ready in the coming months. The core outcome work also resulted in an invitation to join the International STEP Compact collaboration, and this aimed to take a broader view of standardizing outcomes in perioperative medicine, which will then be feeding back into the next stage of the work that we're doing here in Manchester. Now, as I've mentioned before, one of the key attractions to upper GI surgery for me as a specialty was the innovation being used in this field. Minimally invasive surgery was at the center of this attraction. However, in the early 2010s, less than 10% of patients in the UK were undergoing any form of minimally invasive surgery in upper GI cancer. And even though Manchester was a relatively early adopter of minimally invasive surgery, the programs were in their infancy, the procedures were neither stable or stabilized. And importantly, there were several examples of attempts to start minimally invasive surgical programs in upper GI cancer, both in the region and nationally, which didn't progress beyond a few cases. Minimally invasive surgery for me was an area I was especially passionate about because it makes complete sense for patients. Smaller incisions, less pain, fewer pulmonary complications as a consequence of being able to breathe more easily, and ultimately a quicker recovery. And so building on the initial experience gained during my training and that of my colleagues, we set about establishing a minimally invasive esophagectomy or MIO program at Manchester Royal Infirmary. And of course, this technique came over with us when we centralised services to Salford in the NCA back in 2018. And our cumulative experience in GM now has reached well over 400 MIO cases, which is second to none, and it's phenomenal. And now I mention MIO not only because it was an important forward step in terms of innovation, but it also led on to a number of other really important opportunities. As a result of implementing MIO for cancer, not only have we been able to benefit patients in Manchester, but we've also been able to develop an international fellowship training program for surgeons coming from abroad wanting to learn these advanced surgical techniques. And this program is now entering into its 10th year. We've had 5 fellows already in this program with another 2 lined up for next year. And these fellows have already gone back to their respected regions and commenced their own minimally invasive surgical programs to the benefit of their own patients. And through this work, we've also been able to set up international MDTs or multidisciplinary team meetings for complex case discussions and shared learning. But one of the most critical consequences of developing this MIO program was being able to collaborate in a landmark surgical randomized controlled trial, RCT, called Romeo. And this compared minimally invasive surgery for esophageal cancer, or MIO, versus open surgery. Now, for decades, surgical research has been mocked as being of low quality and methodologically shaky at best. And Romeo came to break this mold. And whilst the results were, of course, important, what was more important was the methodological work which underpinned the quality assurance in this surgical trial. For example, we were able to contribute to the development of a core outcome set for esophageal cancer surgery trials, which complements our gastric cancer work. And of course, that will inform the next stage of what we're going to be doing in the region. But we were also able to confirm what many of our anaesthetic colleagues have long known to be true, which is that just because a surgeon says they've done something in an operation doesn't mean they've actually done it. Now, moving swiftly on, complex surgery in older patients with comorbidities, advanced disease, unfortunately means complications are common. And we know from international benchmark studies that serious complications occur in a third of our patients. And the dreaded anastomotic leak, where the surgical join that we make fails to heal, occurs in 10 to 15% of our patients. The consequences of anastomotic leak can be devastating, and so effective patient rescue is critical. Just under 10 years ago, we were early adopters of a technique called endovacuum therapy, which uses negative pressure to accelerate tissue granulation and tissue healing in leaks and esophageal perforations. The use of the sponge, as we refer to it, has also opened up the way for other novel developments in this area, including the use of something called a VAC stent, which combines negative pressure and a covered stent, and which we are in the process of introducing into our armamentarium at Salford as well. And all these innovations, of course, opens up doors to further research opportunities, industry collaborations, and of course, importantly, improved patient outcomes. Finally, specialties like our own also suffer with other significant challenges. Even in high volume centres like our own here in Salford, we still undertake a relatively low volume of cases per year compared to places like South Korea, as I've mentioned before, that performs thousands of these upper GI cancer resections every single year. So for us here in the West and in the UK, it's especially difficult to identify trends and correlation, which means prospective big data collaboration is essential. And the importance of this was demonstrated during the initial phase of the COVID pandemic, when we saw unprecedented changes in the way we worked within healthcare. Within the surgical world, there was a huge initial concern about the safety of laparoscopic surgery, given the potential for airborne spread of the virus. As a result of our international networks from the Gastro study and other collaborations, we were able to lead and quickly turn around an international multi-center study which confirmed the safety of minimally invasive surgery. And the impact of this was that we were able to continue delivering standard of care throughout the entirety of the COVID pandemic, whilst other centers were having to change their practice. Through our networks, we've also collaborated in numerous other big data studies, including those exploring surgery or the safety of bariatric surgery during COVID, the management of early esophageal cancer, and the management of anastomotic leaks and other complications in upper GI surgery. So the big question is, well, what's the relevance of all of this work, and how is it going to help our patients in Manchester? I'm a product of Manchester. I was raised here, I trained here, and so my priority is our patients here. And what I'd say is we now have a really strong understanding of what outcomes are critical to measure in our field. We know how to measure these outcomes, and now what's left is to go out and do it. And this is what the Conquest study, which one of our PhD students will be starting later this year, aims to do for our patients undergoing treatment for esophageal and cancer surgery. It will be the first study to measure all of the core outcomes as identified by the core outcome sets that we developed, and focus particularly, especially on the late effects of treatments, the long-term outcomes that have been poorly reported in surgical trials so far. But we're also in a very strong position to be able to influence a conversation, not just within upper GI cancer surgery, but also across other cancer groups. And as I've mentioned before, we will imminently have a broader core outcome set for us to use, which will inform which outcomes we should be collecting across all surgical cancer specialties. And following some really exciting developments this week within GM cancer, I'm confident that this will be a reality very, very soon. Once we know where we fall short as services, we'll be able to identify areas for improvement and provide the data and the fuel to undertake the high quality studies and trials of the future, all with the aim of course, improving outcomes for our own patients here in the region and further afield. So I'm going to close with a few final thoughts. I've kept the overview as superficial as I could and not covered every area of research activity that I'm involved in, and instead spent a lot of time talking about other people, about mentors, about supporters, supervisors, investors, collaborators, and funders. And this is very intentional because research is very much a team sport. And whilst, as I said, disappointment means a lot to me, I did not achieve this on my own. Secondly, my intention was never to pursue a path into research. And as I shared at the beginning, I was late to the game, but I've never once regretted entering this space. And I believe it has made me a better clinician and a more effective one at that. So my second point to anyone considering undertaking a period of research is that there isn't a wrong or right way or time to do it. And if you are in fact not considering research as an option, be open to how it can augment your ability to do your job better. And my final point is really an invitation to anyone thinking about patient outcomes, whether that be in the clinical or research setting, to get in touch. To get in touch if you think that our team can be of any benefit. We've spent many years refining methodology and creating the solid foundation for reporting and measuring outcomes, both in the clinical and research setting. And importantly, we've kept the patient perspective at the heart of what we do. And it will be a real shame not to put this to good use. Thank you very much.
Brilliant. Thank you, Bilal. That was really insightful and great to learn about your journey through research, and some of the studies that you talked about there were absolutely fantastic. So did anyone on the call want to come in with any questions, comments?
Can I just chip in? So,
Yeah, go ahead,
Bilal, I'm
Bill.
afraid I'm going to have to go to the same meeting. I think Jonathan nipped off
Sure.
to, which is an NIHR meeting we've got actually. So, an emergency meeting. So, just to say thanks very much. That was brilliant. You've done some great work, and it's amazing to see that huge international collaboration. That's a major advance, isn't it? Can I just ask one quick scientific question, really? So, in terms of the current 5-year survival. Of gastric cancer. Is there anything that can be done in terms of earlier diagnosis? Any thoughts on that really? Because very important, isn't
Yeah.
it?
So our 5-year survival, overall survival for all upper GI cancer is in the region of less than 20%, and really hasn't shifted significantly over the last 4 or 5 decades. And that's despite a number of advances in multimodal therapy, chemotherapy, immunotherapy, etc. We are seeing some shifts, but certainly not at the speed that we want to see. And you're absolutely right. The key here is early detection. And there are some developments which we've seen. The team down in Cambridge, Rebecca Fitzgerald, has worked tirelessly over the last 10, 15 years to develop this technique called the cytosponge, which is a device that you swallow. It's a pill. The capsule dissolves, and out comes a sponge, which then we pull out, and then we're able to look at those cells. And this really speaks to the fact that we do not have a screening program here in the UK. One of the reasons why outcomes in the Far East are so much better is the incidence is higher, and therefore there is a buy-in to develop a screening program. But for them, culturally, in the Far East, having an endoscopy is acceptable. Here, the view is very different. Because the incidence of cancer is very small, upper GI cancer is very small compared to other regions, the cost associated with setting up a screening program with endoscopy would just not be tenable here in the UK. And so there is absolutely developments in this field trying to use approaches such as cytosponge, but also using VOCs, the volatile organic compounds, breath testing, to see whether we're able to identify these cancers early on. But you're correct, early diagnosis is key to
No,
this.
no, thanks. So it's high risk people and people with early symptoms, really. Yeah. No, thanks very much. So really enjoyed that, and I can see that your dear wife is on the call, and also Mr.
Hi,
Alkhaffaf.
hi, Phil.
Lovely to see you after all these years. Yeah, great to see
Yeah,
you, and you must be very proud of him. Well done. Yeah,
yes,
great.
yes.
Okay, I'm gonna have to go, but great, great. I'll leave you to
Thanks
it.
very much, Phil. Yes.
Cheers. Bye bye now. Bye.
I just want to say, congratulations to Bilal, an excellent talk, and all the best for the future.
Brilliant. Thank you very much. Bilal, since we're going to be uploading this to the YouTube, I just wanted to address a couple of things myself as well. So I think the first question that I had, you've kind of already covered it in your final thoughts, but I thought the creation of your standard outcome measurements, it's a really brilliant thing. I was just wondering how it would be best to spread this into other specialties across GM, kind of like you mentioned towards the end.
Yeah, so we're already
Yeah.
heavily involved in GM cancer. I personally am involved in the clinical outcomes and data group. And what we're trying to do is use this science, this methodology that we've developed to inform which outcomes we should be accessing and reporting in the region. So there is direct clinical application. We're in that process already. We've got great buy-in from the team in GM cancer, and that will be the first step.
Yeah.
We're also aware of a desire from our own trust, Northern Care Alliance, to really look at how we measure outcomes for all our surgical specialties. And that's something that we're going to use this work to inform. We want to develop some of the patient-reported outcome measures, try to understand how best we capture them using data and using AI, using technology to try and make data capture easy, and then analysis of that data easy as well. Ultimately, it's one thing capturing the data, it's another thing trying to make sense of it in order to identify the areas that we need to focus on to make things better for our patients.
That's brilliant. Thanks, Bilal. So I think we'll call it to a close there. Just a couple of final comments from the people in the chat. So Jonathan said it's really inspiring to hear about your research progression. He hopes other people who will be watching this back really take inspiration from that. And we got a thank you as well from Maddie Harriman, who says she's been working on the Obesity Reimagine workshops that you've been involved in. So it's been really great to get this additional insight. So thanks very much, Bilal. I think we'll call it to a close there. And thanks everyone for joining us today. And yes, we'll see you at the next one of the MAHSC inaugural lectures in May. Thanks very much. Bye bye.